Hello, Medicos. Good day to all of you. This is Dr. BK for you, and today is topic on head and neck is the orbit. So today we are starting with the orbit, and I will be discussing orbit as two classes. So in the first class for today, mainly our learning objectives will be about the bony orbit. Okay, so what are the bones which are responsible for forming the socket for the eyeball, the bony socket? So its walls and features, mainly we will be discussing how it is actually constructed and various features which you see on the each wall of the orbit. Followed by that, a short description on the fascia of the orbit or the orbital fascia. Then we will be discussing about the extraocular muscles of the eyeball. So its attachments, nerve supply, actions and its clinical aspects. So followed by that, about the vessels of the orbit, mainly the ophthalmic artery and the ophthalmic vein, we will be discussing in today's class. So now let us try to understand about the bony orbit. So you are able to see two large cavities in the norma frontalis of the skull, and these are the sockets for the eyeball, and it is a bony cavity. So a bony cavity is mainly for protection. So it protects the eyeball under various injuries or to any harsh due to any climate or because of any other harsh chemicals, whatever it might be. So to put it simply, it is protective in nature, and not only that, this socket also allows free movement of the eyeball. Okay, so mainly seen in the norma frontalis. So you have a pair of orbital cavities, and they both are separated medially by the nasal cavity. Okay, so the nasal cavity separates the two orbital cavities. So it lodges the eyeball or the organ of the sight. So not only it lodges the eyeball, so you all know that the eyeball is actually an outgrowth of the forebrain. So mainly, so it possesses most of the characters along with the meningeal coverings. It is attached to the brain via the optic nerve. Then inside this cavity, apart from the eyeball, you also have muscles which helps to move the eyeball. So this is attached to the outer aspect of the eyeball which helps to move the eyeball. Then you have vessels and nerves supplying these muscles as well as the eyeball itself. Certain outer layers of the eyeball is supplied by the vessels outside the eyeball. Then you have a variable quantity of fat. Okay, so that is also a content of the orbit. So as I told you, they are separated by the nasal cavity which you are able to see here. Now let us try to understand this bony cavity. Now how actually it looks. Basically it is pyramidal in shape, and this pyramid is not actually lying straight like this. It is laid horizontally and not exactly antero-posteriorly, but it is laid to one side. That means the base of the pyramid forms your orbital margin, and the apex of the pyramid is not exactly at the opposite end, but it is actually directed somewhat medially. So posterior-medially you have the apex. So both the apex are somewhat nearer to the median plane or mid-sagittal plane. That is one thing. Now why it is like that? because the medial wall are parallel to each other, whereas if you look at the lateral walls, they are converging. The lateral walls actually converge towards the apex. So a pyramidal shaped cavity with the lateral walls converging. Now because of this, you are able to see these two are like two projecting like your telescope. So mainly it is for our binocular vision. Okay, that is how the orbit is constructed. So you get a very wide area of vision, that too with both the eyes. For the to facilitate or to bring about this binocular vision, this orbit is actually what happens is it is in a pyramidal shape with the pyramid lying to one side. Now coming to the boundaries of the orbit, as I told you, it has got a base. It has got an apex. Then you have a roof, floor, medial wall and a lateral wall. Okay. So these are the boundaries or walls of the orbit. Roof, floor, medial wall and the lateral wall. And it has got an apex and also a base, as I told you. The base, if you look at it, it is formed by what you call it as the orbital margin. And the eyeball actually projects, you can tell to some extent beyond the base, because if you pass a needle through the lateral angle of the eye, it passes behind the lens of the eyeball. Okay, so laterally if you pass, what happens is a sharp object, it passes behind the lens of the eyeball, especially to the lateral angle of the eye. Whereas anteriorly, any blunt object cannot hurt the eyeball because the orbital margins are projecting anteriorly. Okay. So I told you this is actually lying to the one side. So that is how you are able to see your both the sockets are present. The medial wall is actually parallel. The lateral wall is converging. So you have two like your car headlamps. But car headlamps again is also not projecting like this. So our eyes mainly for the binocular vision it is present. This is actually your orbital axis which runs from the middle of the base to the middle of the apex. Whereas you are able to see the optical axis which runs anterior-posteriorly through the eyeball. So the visual axis and the optical axis are not the same. Okay, they are not actually the same. There is almost a difference or angulation of around 25 degrees between the orbital axis and the optical axis. Again, visual axis differs. Now, when the eyeball abducts, then you can see your optical axis and the orbital axis becomes the one. So, optical axis lies parallel to the orbital axis. Okay, so that is about the basic features of the orbital cavity. Now, so here you are able to see the orbit, that is the orbital margin. So if you, as I told you, if you pass a sharp object from the lateral wall, it will cross beyond the lens of the eye. But anteriorly when you approach, you are able to see these projecting orbital margins. They prevent any direct blow to your eyeball. So at the apex, mainly you are able to see this opening the optic canal. The optic canal transmits the optic nerve and the ophthalmic artery. But for all practical purposes, the apex is actually this thin part of bone which is present between the optic canal and the superior orbital fissure, this thin part of bone. Orbital margin is mainly formed by the frontal bone, zygomatic bone, and then the maxilla. Frontal, zygomatic and maxilla contributes for the orbital margin. If you trace the frontal bone medially, it forms the posterior lacrimal crust, continues with the posterior lacrimal crust. Here you are able to see that. Anteriorly, if you trace the margin, infraorbital margin, it is continuous with the anterior lacrimal crust. So between the posterior lacrimal crust and the anterior lacrimal crust, you have the lacrimal fossa. Okay. So what lodges in the fossa is the lacrimal sac, and that is lined by a fascia which is called as the lacrimal fascia. So apex deeper inside, and that is the base. Okay. Orbital index is maximum breadth by maximum depth into 100. Okay. That is your roof, your lateral wall, the floor and the medial wall of the orbit. So now let us try to understand each and every wall and the features present on it. So apex is mainly formed by the optic canal, as I told you, which transmits your optic nerve. So second cranial nerve of the vision, and ophthalmic artery, optic nerve and ophthalmic artery, it is present, which is transmitted by the optic canal along with its dural sheath. So the meninges also prolong along with the optic nerve. Base is formed by the orbital margin, and I told you extensively, I have discussed about the orbital margin. And in the medial part, you are able to see a supraorbital notch, sometimes converted into foramen, to transmit the supraorbital vessels and nerves. Now, we are finished with the with the apex and the base. Now coming to the roof of the orbit, it is mainly formed by the orbital plate of frontal bone. This is actually the orbital plate of the frontal bone, which forms the roof anteriorly, and posteriorly it is actually contributed by the lesser wing of the sphenoid. So behind you are able to see that is the lesser wing of the sphenoid. So these two bones contribute for the roof of the orbit. This roof separates the orbit from the anterior cranial fossa, which is above the roof. So the floor of the anterior cranial fossa is again formed by your orbital plate of frontal bone. So features on the roof, mainly anteromedially, you come across a notch or pulley which is called as the trochlear notch. So this is a notch, and the anteromedial, near to the junction of the roof and the medial wall, you have the trochlear notch. So this trochlear notch gives attachment to a fibrocartilaginous structure, and between this notch and the fibrocartilaginous pulley, what passes is the superior oblique muscle. So superior oblique muscle will actually pass through this and then turn its direction to go behind. Okay, so that is the trochlea, which gives attachment to the fibrocartilaginous pulley, through which the superior oblique muscle passes and then changes its direction. One of the extraocular muscle. Then superolaterally you come across a depression which is mainly formed by the lacrimal fossa. That is the fossa for the lacrimal gland. Don't confuse this lacrimal fossa with here also you have a fossa here between the anterior lacrimal and the posterior lacrimal crest, which lodges the lacrimal sac. So this you are able to see on the superolateral part of the roof, which lodges the lacrimal gland, and trochlear notch in the supromedial part, which I already told you. Then posterior part of the roof. So near to the posterior part of the roof, the junction of the roof and the medial wall, you see the optic canal. So optic canal transmits the optic nerve and the ophthalmic artery. Here you are able to see the optic nerve along with the ophthalmic artery situated inferolateral to the nerve. It emerges from the optic canal. Okay, so this is your roof structure mainly formed by the orbital plate of frontal bone. This is your lesser wing of sphenoid. This is superior orbital fissure, which is between the lesser wing of sphenoid, and this part is the orbital surface of greater wing of sphenoid. Superior orbital fissure. Here you see the inferior orbital fissure, which is between the again greater wing of sphenoid and zygomatic laterally. Orbital surface of maxilla medially. This is inferior orbital fissure. Superior orbital fissure transmits many structures. I will be speaking about the superior orbital fissure in the second part of the orbit. Okay, so it will be divided into a lateral part, an intermediate part, and then the medial part by a musculotendinous ring, or it is also called as tendon of Zinn. Okay, so we will come to it later. So now coming to the floor of the orbit, it is mainly formed by the orbital surface of the maxilla, as I told you. Laterally, it is supplemented by the zygomatic bone. Laterally, it is supplemented by the zygomatic bone. You are able to see that, and more posteriorly and medially, it is by the palatine bone, orbital plate of palatine bone. Features infraorbital groove you are able to see, which transmits the infraorbital vessels and nerves, and that opens into the infraorbital foramen, through which the infraorbital nerves and vessels they emerge. So mainly on the floor you see the infraorbital groove and canal, which is leading to the infraorbital foramen, transmits the vessel and nerves of the same name. They are branches of the maxillary nerve and artery. Infraorbital nerve is considered as the terminal part of the maxillary nerve. The next wall is the lateral wall, strongest wall of the orbit. Of the four walls, the lateral wall is strongest. Okay, because it has to withstand the forces of mastication. So here you have the molars, premolars. So it has to actually withstand the forces of mastication. So it is actually the strongest wall, mainly formed by the zygomatic bone. Okay, and then more posteriorly the orbital surface of the greater wing of the sphenoid. The zygomatic bone and the greater wing of the sphenoid forms the lateral wall of the orbit. What are the features on the lateral wall of the orbit? Mainly you come across two foramen, zygomatico-facial foramen and temporal foramen, which transmits the nerves of the same name, zygomatico-temporal and zygomatico-facial. They are all again branches of the maxillary nerve. They are responsible for the cutaneous innervation of the face. Then you come across laterally one more small tubercle, which is called as the Whitnall's tubercle. The Whitnall tubercle will actually give an insertion to the lateral palpebral ligament. The lateral palpebral ligament will give attachment to the orbicularis oculi muscle, mainly the palpebral part. Then it will also give attachment to lateral check ligament and the suspensory ligament of the eyeball. Okay, so lateral check ligament and suspensory ligament of the eyeball I will discuss while I discuss the orbital fascia and the bulbar fascia. So mainly you come across Whitnall's tubercle, which gives insertion for the lateral check ligament, suspensory ligament of Lockwood, and then your lateral palpebral ligament. Superior orbital fissure is at the junction of posterior part of the roof and the lateral wall. So I have just in the last slide I have discussed about the superior orbital fissure, how it is divided to lateral, intermediate, and then the medial part by a musculotendinous ring surrounding it and enclosing the optic canal. So inferior orbital fissure is seen between the lateral wall and the floor, and from here what is extending on the floor is a infraorbital groove, which transmits the infraorbital vessels and nerves. So finally, the last wall of the orbit is the medial wall. So here you are able to see the medial wall. From before backwards, it is formed by 4 bones, and this is the most thinnest wall. So comparative to the other 3 walls, this wall is very thin and mainly formed by the 4 bones. Frontal process of maxilla. So that is the first bone. Behind that, it is formed by the lacrimal bone. Then it is formed by the orbital plate of ethmoid bone, and finally, more posteriorly, the body of the sphenoid. So 4 bones from before backwards mainly form the medial wall of the orbit. So mainly 4 bones you are able to see: frontal process of maxilla, then you see the lacrimal bone, then you see the orbital plate of ethmoid, and finally what you come across is the body of the sphenoid. So what features you come across in this is 2 foramens, anterior and posterior ethmoidal foramen you come across in the medial wall. They transmit the anterior and posterior ethmoidal vessels and nerves. They are branches of the ophthalmic nerve and the ophthalmic artery. Anterior and posterior ethmoidal vessels and nerves are transmitted. That is one feature you come across. Then you see the fossa for the lacrimal sac. So it is present between the anterior and posterior lacrimal crest. Anterior and posterior lacrimal crest, which is this between the stretching is the lacrimal fascia. So deep to the fascia, the sac is present where the lacrimal fluid is collected, and it is drained by the nasolacrimal duct into the inferior meatus of the nose. Okay, so that is about the medial wall. So we have finished with the body orbit, the features of the body orbit. Now coming to the orbital fascia, so which lines the bones of the orbit. All the walls, body orbit is lined by a fascia, which is called as the orbital fascia or periorbita. So the other name for it is the periorbita. It is the orbital periosteum, and it loosely invests to the bone. So it is not very tightly adhered to the bone. It is very loosely investing the bone, and it sends extensions into the upper and lower eyelid tarsal plates as the orbital septum. Okay, so posteriorly it will be continuous with the dura of the optic nerve. Posteriorly it will be continuous with the dura mater of the optic nerve. So orbital septum is extension of the fascia attaching to the tarsal plates. Okay, so it will get attached to the tarsal plates, which you are able to see here, the orbital septum. Okay, so that is getting attached to the inferior and the superior tarsal plate. So modifications, one modification we have seen is the lacrimal fascia. One is the lacrimal fascia is one of the modification. So which stretches between the anterior and posterior lacrimal crest. So this is your lacrimal fossa. So you are able to see here, and that will be actually lined by a fascia. The next modification is the inferior orbital fissure will be bridged again by a muscle, and that is a modification of the orbitalis muscle. So it bridges across the inferior orbital fissure, the orbital fascia. Okay. So here, then one more modification is, so this fibrocartilaginous pulley which attaches to the trochlear notch, and what passes through that is the superior oblique muscle tendon. So that fibrocartilaginous pulley is again what happens is contributed by the orbital fascia. So that holds the fibrocartilaginous pulley of the superior oblique muscle. So now we will just try to list out the contents of the orbit. So mainly it consists of the eyeball, and fascia covering the eyeball is called as the fascia bulbi. So fascia bulbi is different from the orbital fascia. Orbital fascia is a periorbita or orbital periosteum which loosely invests the bone attached to the bone, whereas around the eyeball you have a fascia. It is like a secondary socket for the eyeball. The biggest primary socket is your orbit itself, and you have the secondary socket is the fascia bulbi. Then you have the extraocular muscles which helps to move the eye in various directions. Then you have the muscles and vessels, mainly the nerves, third, fourth and sixth cranial nerve, and ophthalmic division. Ophthalmic division of the trigeminal nerve. So ophthalmic artery, superior, inferior, ophthalmic vein, lacrimal gland superolaterally. You are able to see the lacrimal gland is also situated within the junction of the roof and the lateral wall, and then variable amount of fat, because fat, I told you, it is a loose packing material. So where all spaces are there, what happens? It serves as a packing material so that it prevents any mechanical injury to the eyeball during various movements. Okay. So now we will pass on to the extraocular muscles of the eyeball. So the extraocular muscles, mainly there are 7 muscles, voluntary muscles. The 7 voluntary muscles are mainly the 4 recti and oblique muscles. So there are 4 recti muscles and you have 2 oblique muscles. 7 voluntary, okay. So of these, of the 7 voluntary, 6 muscles, 4 oblique and 4 recti and 2 oblique, they move the eyeball, whereas the 7th muscle is to elevate your upper eyelid, and it is called as the levator palpebrae superioris. Okay, one muscle elevates the upper eyelid called as the levator palpebrae superioris. Recti are superior, inferior, medial and lateral rectus, and superior and inferior oblique. There are also muscles, involuntary muscles also there outside the eyeball. 3 muscles are there: superior tarsus, inferior tarsus, and then the orbitalis muscle. So these are extraocular muscles. Same way, inside the eyeball also you have sphincter pupillae, dilator pupillae, and then the ciliaris muscle. So they are mainly for accommodation. So we will discuss about the extraocular muscles in detail. First we will start with the recti muscles. So there are 4 recti: superior rectus, inferior rectus, then you have the medial rectus, and then the lateral rectus. All the recti origin from this ring, tendon of Zinn. Okay, so the tendon of Zinn is actually bridging across the superior orbital fissure and divides the superior orbital fissure, as I told you, into a lateral, intermediate and then a medial part. Okay, so as it bridges and encloses the optic foramen within the intermediate part, and finally it crosses the superior orbital fissure to attach to the greater wing of the sphenoid. So recti muscles arises from the respective aspects of this musculotendinous ring, the tendon of Zinn. Superior aspect from superior part, inferior from inferior, medial and lateral from the respective medial and lateral aspects. Okay. Of this, the lateral rectus alone arises as the 2 heads. Okay, so the lateral rectus arises at 2 heads, and abducen nerve is actually present between the 2 heads of the lateral rectus. Now where actually these muscles they get inserted? So they are inserted into the sclera of the eyeball. So you are able to see all the muscles. The 4 recti muscles are inserted into the sclera of the eyeball in front of the equator. Equator passes exactly at the center, dividing it into 2 halves. In front of the equator of the eyeball, all the recti muscles are actually inserted. Okay. So, and behind the sclerocorneal junction, and they are inserted in a spiral manner. So, that is about the insertion of the recti muscles, 4 recti muscles, how they are inserted. They are inserted in the sclera in front of the equator of the eyeball. Okay, they are inserted in front of the equator. I told you behind the equator, but not in behind, it is front and behind the sclerocorneal junction. Now coming to the oblique muscles, you have one, the superior oblique muscle. So you are able to see that is the superior oblique muscle. This is your superior rectus. It superior oblique arises from the lesser wing of sphenoid roof, under surface of the lesser wing of sphenoid, from the roof, from the medial to common tendinous ring. Okay, the muscle will pass actually forwards along the medial margin of the rectus, upper margin of the medial rectus, at the junction of the roof and the medial wall. It passes through a fibrocartilaginous pulley, and then what happens is, then the muscle changes its direction. It goes backwards and downwards below the superior rectus, and inserted into the sclera behind the equator at the posterior superior quadrant of the eyeball. So the tendon, after passing through the trochlear pulley, fibrocartilaginous pulley, changes its direction, goes backwards and laterally under the superior rectus and inserts into the posterior superior quadrant of the eyeball behind the equator. So that is the direction of the superior oblique muscle. Upper margin of the medial rectus, it passes, and then after passing through the pulley, it turns downwards and backwards and laterally behind the equator and the posterior superior quadrant. Superior oblique muscle. Next muscle is the inferior oblique muscle. The inferior oblique muscle arises from the orbital surface of maxilla, on the floor of the orbit. And then what happens is, muscle first passes backwards. Medial side you are able to see. That is the oblique muscle. First it passes actually backwards and laterally below the inferior rectus. Below the inferior rectus, it passes backwards and laterally, and also under cover of the lateral rectus, and inserted into the sclera behind the equator at the posterior superior quadrant, nearer to the superior oblique. Nearer to the superior oblique, after turning upwards and backwards. Okay. So it turns this backwards and laterally, this turns upwards and backwards, again into the posterior superior quadrant of the eyeball behind the equator. Okay, so origin from the orbital surface of maxilla, as I told you, the muscle passes backwards and laterally and inserted into the sclera. Nerve supply. The 4 recti muscles, superior rectus, inferior rectus and medial rectus, except the lateral recti, and one of the oblique muscle, inferior oblique, is supplied by the oculomotor nerve. So the dictum is SO4 and LR6, which is superior oblique is by the 4th cranial nerve and lateral rectus is by the 6th cranial nerve or the abducent nerve. Superior oblique and lateral rectus. The remaining muscles are actually supplied by the oculomotor nerve through its 2 divisions, superior and inferior rami of the oculomotor nerve, including the levator palpebrae superioris. So of the 7, you exclude the superior oblique and lateral rectus, and all the remaining 5 muscles are actually supplied by this oculomotor nerve or the 3rd cranial nerve. Now we will come to the levator palpebrae superioris. So levator means elevating eyelid, palpebrae upper eyelid. So that is why it is labeled as levator palpebrae superioris. So again, under surface from the lesser wing of the sphenoid, it passes above the superior rectus. The muscle actually passes above the superior rectus. Then anteriorly it forms a flat tendon and which aponeurosis. Okay, and it divides into three lamellae. The tendon actually splits into three lamellae: superior lamellae, then intermediate lamellae, and then the inferior lamellae. Superior lamellae will attach to the skin of the upper eyelid. Okay, it divides into three lamellae. Superior lamellae or upper lamina inserts into the skin of the upper eyelid. The intermediate lamellae forms the superior tarsus muscle or Muller's muscle. This is actually called as the Muller's muscle because it is not supplied by the general efferent fibers, somatic efferent fibers. They are actually supplied by the sympathetic fibers. Okay, they are mainly supplied by the sympathetic fibers. The Muller's muscle, intermediate lamellae, forms the superior tarsus muscle or the Muller's muscle. It is again involuntary. So if the sympathetic fibers are damaged in case of Horner syndrome, then what happens is it produces the ptosis or drooping of upper eyelid. Lower lamellae inserts into the superior fornix of conjunctiva. Okay, so conjunctiva has got a palpebral conjunctiva which lines your eyelid and reflects on top of the eyeball as the bulbar conjunctiva. The place where the palpebral and bulbar conjunctiva are continuous, that is called as the fornix or fold, superior fornix and inferior fornix. So the deep lamellae is attached to the superior fornix of the conjunctiva. Nerve supply, it is by the upper division of oculomotor nerve, and Muller's muscle is by the sympathetic fibers. Okay, which is actually coming plexus surrounding the ophthalmic artery. Plexus which is surrounding the ophthalmic artery. So drooping of upper eyelid, if these sympathetic fibers are damaged to the Muller's muscle, ptosis occurs. Drooping of upper eyelid most commonly in the Horner syndrome. Okay, where the lower trunk of brachial plexus is damaged. So its action is elevates the upper eyelid. Then, what are medial and lateral check ligaments? They are nothing to do with the levator palpebrae superioris. They are modifications of fascia bulbi. So fascia bulbi is a fascia which surrounds the eyeball, external to the sclera. So between that fascia and the sclera, again you have episcleral space. Now this fascia, what happens is it attaches to the Whitnall's tubercle laterally. Same way it also attaches to the medial wall, forming the check ligaments. It also gives facial extensions to the extraocular muscles. So it gives extensions to the muscles, medial rectus, lateral rectus, inferior rectus, and then attaches as medial and lateral check ligaments. So the check ligaments mainly check the contraction of these muscles, mainly medial and lateral check ligaments. Then it also forms inferiorly the suspensory ligament of Lockwood. So this supports the eyeball from below. Okay, so that is called as the suspensory ligament of Lockwood, apart from the medial and lateral check ligament. I told you lateral check ligament attaches to the Whitnall's tubercle. So these are all modifications of the fascia bulbi or bulbar fascia. Now coming to the actions of extraocular muscles. Now first of all, the medial rectus and the lateral rectus. Okay, they lie in a same transverse plane. The medial rectus and lateral rectus, they are actually lying in the same transverse or horizontal plane. Okay, next coming to the superior rectus and inferior rectus, they lie in an oblique plane which is directed forwards and laterally. So it is actually directed forwards and laterally. 25 degrees, it makes an angle with the optical axis. With the optical axis, it makes an angle of 25 degrees. Okay, here you are able to see that forwards and laterally it makes an angle with the optical axis. It is 25 degrees. Now if the eye abducts, then what happens is the optical axis and the rectal axis, the axis of superior inferior rectus will become the same. They both will coincide. Okay. The next superior and inferior oblique. Superior and inferior oblique again lie in an oblique plane. You are able to see the insertion of superior and then inferior oblique nearer to it. They lie in an oblique plane which is directed backwards and laterally. So they are actually directed backwards and laterally. So when the eye is adducted, when an adducted eye, what happens? This optical axis will coincide with the oblique axis, which is directed backwards and laterally. Whereas the rectal axis, superior inferior rectus, is directed forwards and laterally. So all movements of the eyeball occurs around an axis which passes through the equator of the eyeball. And always remember that whether any movement of the axis, any movement of the eyeball, whether it is adduction, abduction, elevation, depression, intorsion, extorsion, some amount of rotation takes place. Okay. So elevation and depression takes place around a transverse axis. Elevation and depression. Adduction and abduction takes place around a vertical axis. Any movement will takes place around the axis, not parallel but around to the axis. Okay. So elevation and depression, this will be the transverse axis. Eyeball will move around the axis up and down. Okay. Then next is, I told you, the adduction and abduction around a vertical axis. It will move like this, adduction and abduction, whether right or left. Then you have one more axis which is passing through the eyeball as the antero-posterior axis, and around the axis the movement is intorsion and extorsion. Okay, so that is called as intorsion and extorsion around the antero-posterior axis of the eyeball. So here you are able to see the actions of the eyeball in primary position, in adducted and then the abducted position, mainly superior, inferior, rectus and oblique. Because the medial and lateral rectus, they produce only adduction, abduction, not any other movement. Medial rectus produces adduction and lateral rectus produces the abduction. So now let us try to understand the actions. In the primary position, what is the action of eyeball? Medial rectus, adduction. Lateral rectus, abduction. Okay. Superior rectus brings about superior, so it brings about elevation and intorsion. Okay. Inferior rectus brings about depression and extorsion. Okay. So it brings about depression and extorsion. Superior rectus brings about elevation and intorsion. Opposite of superior rectus is superior oblique. Superior oblique brings about mainly depression. So that is why downwards it brings about depression and intorsion. Superior oblique brings about depression and intorsion. So what do you mean by this? Superior rectus and inferior rectus, with respect to elevation and depression, they are opposite actions, but both brings about intorsion. Both their superiors bring about intorsion. Inferior oblique brings about elevation, but they produce extorsion. So which means both the inferiors are extorsion, apart from the elevation and depression, which is opposite. Inferior rectus depresses the eyeball, whereas inferior oblique actually elevates the eyeball, but both brings about the extorsion. So these are the actions of the eyeball in the primary position. Now, for example, if the eyeball is adducted, then superior rectus in the adducted position will bring about intorsion, and in abducted position it will bring about only elevation. That is what I have given in the table. Same way, if you look at the next, the inferior rectus in adducted eye will bring about only the extorsion, and in an abducted eye it will bring about depression. So this will actually bring about intorsion in an adducted eye. In an abducted eye it will bring about elevation, but here this in an adducted eye inferior rectus will bring about extorsion and abducted eye will bring about depression. Superior oblique in an adducted eye will bring about depression only, and in an abducted eye it will bring about intorsion only. Inferior oblique in an adducted eye it will bring about elevation, and abducted eye it will bring about extorsion. Okay, so this is just action of the oblique muscles. So mainly the superior oblique brings about elevation. Okay, it brings about superior oblique naturally should bring about intorsion and depression of the eyeball. So this is around the vertical axis. You can see movement around the vertical axis, which is adduction and abduction, which is brought about by the medial rectus and the lateral rectus. Okay, so they bring about the adduction and abduction of the eyeball. So next you look is the conjugate movements when both the eyes move in the same direction, so with the visual axis being parallel. So like scanning a person, you are able to see both the eyes are moving to one direction. So when it moves towards the left side it is called as levo-rotation. When it moves to the right side it is actually called as the dextro-rotation. So both the axis of the visual axis will be the parallel, both eyes moving to the same side. Next you have like conjugate movements. You have disjugate movements, convergence, and it is called as the divergence. Okay, so what is convergence and divergence is when both the eyes move around a vertical axis. So now you are able to see this is convergence, both eyes moving to the medially, whereas divergence is when they are moving from each other. And remember, in this the visual axis of both the eyes are not parallel. So this is called as disjugate movement. Same way you also have circumvergence when both the eyes move in opposite directions. That means one will move medially, other will move laterally. If this eye is coming medially, this eye will move laterally. That is actually called as the circumvergence. Okay, so these are associated movements like your conjugate movements and the disjugate movements. Now, balanced action of the four recti gives stability. Antero-posterior stability is mainly by the superior inferior rectus, medial lateral rectus exerting a pull from the behind. Okay, so they have an exert over the behind, whereas the obliques will give a traction towards the front. So what happens is obliques pulling from the front. So this gives the stability, and apart from that you have the check ligaments also. So now coming to the clinical aspects, if any of the muscle is paralyzed, it is called as strabismus or squint. So strabismus or squint. Different types of strabismus or squint is there. So unilateral paralysis mainly occurs. You see diplopia or double vision. So most common symptom you see is diplopia or double vision. And when actually the diplopia or double vision occurs? In internal strabismus. So this is actually internal strabismus. This is the normal eye. Here you are able to see the lateral rectus is paralyzed. So due to unopposed action of lateral rectus, the eyeball is pulled medially. This is actually called as internal strabismus due to paralysis of lateral rectus. Abducent nerve might have damaged. So in this case, what happens is diplopia appears on looking to the paralyzed side. When you try to look laterally, then you see diplopia, double vision. If the medial rectus is paralyzed, then due to the unopposed action of lateral rectus, the eyeball is pulled laterally. Okay, now diplopia or double vision occurs when you try to look at the sound side. So this side, your sound side, when you try to look at the sound side, then naturally what happens is you get diplopia or double vision. Same way, this is paralysis of superior rectus. Okay, paralysis of actually superior rectus, paralysis of inferior rectus. Now, in case of paralysis of superior rectus and inferior rectus, the false image is obliquely disposed. So, superior rectus, when you try to look up, you will have diplopia or double vision. Inferior rectus paralysis, when you try to look down, naturally you will have diplopia or double vision. In case of the obliques, when the superior oblique is affected, diplopia occurs on looking down and the false image lies outside the true image. Whereas if the inferior oblique is affected, you get diplopia or double vision and looking up and the false image lies outside the true image. So this is about the strabismus or squint. So next, involuntary muscles. So involuntary muscles are unstriped muscles. They are extraocular muscles. Superior tarsus derived from the intermediate lamellae, which is attached to the tarsal plate. Superior tarsus muscle. The next is the, what you come across is the inferior tarsal muscle. So it connects the inferior tarsus to the fascia of inferior rectus and inferior oblique. So they assist in the depression of lower eyelid, and one more is orbitalis muscle, which stretches across the inferior orbital fissure. So finally, coming to the ophthalmic artery. So the main vessel which supplies the structures in the orbit. It is actually a branch of external carotid artery. So ophthalmic artery is actually a branch of external carotid artery. Enters through the orbit through the optic canal. So after passing through the lateral wall of the cavernous sinus, this is the medial clinoid process. It emerges medial to the medial clinoid process, and there it gives the ophthalmic artery which passes through the optic canal. It is first lying inferolateral to the optic nerve, and then what happens is then it crosses the optic nerve from the lateral to medial side and runs along the medial wall of the orbit. And divides into two terminal branches. One is the supratrochlear artery and other one is the dorsal nasal artery. Okay, supratrochlear and dorsal nasal artery. Dorsal nasal artery anastomoses with the branch of facial artery. So thereby, the ophthalmic artery maintains communication between the anastomosis between the internal carotid and external carotid. One is actually connection with the branch of the facial artery, as I told you, lateral nasal artery, and other one it will have communications with the maxillary and superficial temporal. So thereby it maintains communication with the anastomosis between the superior and external and internal carotid arteries. Now coming to the branches to the eyeball, mainly what you have is the central artery of retina. Okay, so it arises below the optic nerve, pierces the sclera. Okay, and then what happens? It supplies the optic nerve and the inner 6 layers of the retina. It is an end artery. If the artery is occluded, then naturally it leads to blindness. Okay, central artery of retina. Next artery, what you have is the posterior ciliary arteries, which is got two divisions, long and short posterior ciliary arteries. The long posterior ciliary artery is actually 2 in number. Short posterior ciliary arteries are actually 5 to 6 in number. So they anastomose with the anterior ciliary branches and supply the iris and ciliary body. Okay, so mainly they supply the iris and ciliary body, long posterior ciliary arteries. Anterior ciliary arteries are from the muscular branches. Both the anastomoses and they form a plexus, capillary plexus. Short posterior ciliary arteries will supply the choroid and the outer layers of the retina, outer 3 to 4 layers. Inner 6 to 7 layers is actually supplied by the central artery of retina. The short posterior ciliary artery supplies the choroid, that is the vascular layer of the eyeball, and then the outer layers of the retina. Then muscular branches to the extraocular muscles. On the lateral wall, it gives the lacrimal artery. So it supplies the lacrimal gland and also the eyelid, palpebral branch it gives, and also supplies the conjunctiva. It gives a recurrent meningeal branch which will anastomose with the middle meningeal artery. Recurrent meningeal branch of lacrimal artery which pass through the superior orbital fissure. Okay, so lateral branch is mainly the lacrimal artery which you are seeing here. Then the remaining arteries are actually from the medial wall. Along the medial wall you have anterior and posterior ethmoidal arteries. So they supply the ethmoidal sinus and also the nasal septum. Anterior and posterior ethmoidal arteries. Then you have the medial palpebral which divides into supratrochlear and supraorbital. So they are blood supply to the medial part of the forehead and also to the scalp. Then you have dorsal nasal artery which anastomoses with the facial artery. So kindly excuse with the spelling, somehow a mistake has happened here. It is FACIAL. Okay. So medial wall mainly it gives anterior posterior ethmoidal arteries and medial palpebral and dorsal nasal artery. So that is mainly about the ophthalmic artery. Ophthalmic vein, superior ophthalmic vein. So they accompany the ophthalmic artery, receives tributaries of the corresponding branches to the artery and drains into the cavernous sinus. Communicates with the facial vein, one through angular vein. Okay, this superior ophthalmic vein will have communication with the facial vein through the angular vein. Inferior ophthalmic vein from the floor of the orbit drains the infraorbital muscles, lacrimal sac, medially you see, and then finally it might join the superior ophthalmic or drain directly into the cavernous sinus. So that is about the superior and inferior ophthalmic veins. So thank you very much, and I will continue with the orbit in the second part with respect to the nerves of the orbit.